Good evening. Today is June 19th, 2019, and it is 5:34. As a quorum of the board is in attendance, I would like to call the order of the meeting of the Central Health Board of Managers. The first item of business is citizens communications. Lisa?
Good evening. My name is Anais Cruz, Program Manager here at Central Health. I'm going to kick off citizens communication tonight. We only have one speaker. That's Dr. Charles Bell on our Board of Managers.
Members, I just want to take a very short period of time to make you aware that I posted two suggestions on the board initiatives on the message board. So, two board initiatives on the message board. The board member buddy program and annual or biannual meetings with the Austin City Council. I've spoken with a few members about these initiatives and they were in favor of implementation. Please see the descriptions I've posted. If there are concerns, please either reply or post or speak with me in person. Thank you very much.
Thank you, Dr. Bell.
Thank you.
That concludes citizens communication for tonight.
Thanks, Lisa.
Thank you.
All right. Agenda items 8, 9, and 12 will not be discussed this evening. Those items are 8, discuss and take appropriate action on the healthcare service delivery expansion Eastern Travis County, including project budgets and project timelines. 9, discuss and take appropriate action on the Central Health owned or occupied real property and potential property for acquisition and or lease, including the downtown campus and properties located in Eastern Travis County. And 12, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the fiscal year 2019 strategic work plan and operational priorities, B, an assessment of systems and processes, and C, other personnel matters. I'd like to take up the consent agenda first. C1, approve the minutes of the May 29, 2019 meeting of the Central Health Board of Managers. C2, receive a report of the May 2019 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the May 2019 financial statements for the Community Care Collaborative as presented to the Budget and Finance Committee. And C4, receive the May 2019 investment report and ratify Central Health investments for May 2019.
So moved. Second.
Okay, I have a motion by Manager Valdez, seconded by Manager Greenberg. Any discussion? Not seeing none. Do I hear, all in favor say aye.
Aye.
All against say no. Any abstentions? Motion passes. Now we're on to the regular agenda. Agenda items 2 and 3 will be taken together. Well, no. Agenda item 2 will go first. Agenda item 2, discuss and take appropriate action on the resolutions recognizing the contributions made by State Senator Kirk Watson, State Representative Donna Howard, and State Representative Gina Hinojosa in support of Central Health. Right now, I'd like to recognize in the room their staff. With Senator Watson's office, Sandy Guzman. Did I see Sandy?
She's on her way.
Oh, she's on her way, okay. In Representative Gina Hinojosa's office, we have Cecilia Kay. And from Representative Donna Howard's office, Renzo Soto. Thank y'all for coming. Mr. Beasley.
Yes. So I'll begin with Representative Howard. Whereas the ability to appoint contract for employed physicians to practice medicine will provide flexibility to Central Health to proactively manage its members based on their medical needs and improve their health outcomes while improving efficiency, reducing costs, and most importantly, improve the health of our community. And whereas Representative Howard was the author of House Bill 2976 and the sponsor of Senate Bill 1142, which authorizes Central Health to appoint, contract for, or employ physicians and better fulfill its statutory mandate to provide medical care for the indigent and needy residents of Travis County. And whereas Representative Donna Howard, in her role as state legislator, has filed numerous pieces of legislation dedicated to improving health outcomes for the people of Texas, especially for people who are uninsured and lack access to health care. Now therefore be it resolved by Central Health that the Board of Managers hereby declares its sincere appreciation and gratitude to Representative Donna Howard for sponsoring and passing Senate Bill 1142 relating to the authority of the Travis County Healthcare District, DBA Central Health, to appoint, contract for, or employ physicians to practice medicine. for Representative Hinojosa. Whereas a local provider participation fund, an LPPF, will provide flexibility on how Travis County pays for and delivers health care, while providing safety net hospitals in Travis County a funding source to draw down federal Medicaid funds that meet current regulatory requirements without an increase in taxes on the residents of Travis County. Whereas Representative Gina Hinojosa was the sponsor of Senate Bill 1350, which authorizes Central Health to create an LPPF to secure local matching fund for participation in the hospital supplemental payment programs that benefit local Travis County residents served by Central Health. And whereas Representative Gina Hinojosa, in her role as Vice Chair of the House Committee on Human Services, is dedicated to improving health and human service outcomes for the people of Texas, and especially for people who are uninsured and lack access to health care. Now, therefore, be it resolved by Central Health that the Central Health Board of Managers hereby declares its sincere appreciation and gratitude to Representative Gina Hinojosa for sponsoring and passing Senate Bill 1350 relating to the creation and operations of a local provider participation fund by the Travis County Healthcare District, Central Health. And then for Senator Kirk Watson. Whereas a local provider participation fund will provide flexibility on how Travis County pays for and delivers health care, while providing safety net hospitals in Travis County a funding source to draw down federal Medicaid funds that meet current regulatory requirements without an increase in taxes on the residents of Travis County. Whereas Senator Kirk Watson was the author of Senate Bill 1350, which authorizes Central Health to create an LPPF to secure local match funding for participation in the hospital supplemental payment programs that benefit local residents of Travis County served by Central Health. Whereas historically, Central Health was permitted to employ physicians only to work in its federally qualified health center, community care, or to serve in the capacity of providing policy, administrative, and managerial services, but not to provide direct care. Whereas Senator Watson was the author of Senate Bill 1142, which authorizes Central Health to appoint, contract for, or employ physicians to practice medicine and better fulfill its statutory mandate to provide medical care for the indigent and needy residents of Travis County. And whereas Senator Kirk Watson in 2011 presented 10 goals in 10 years to transform the health and economy of Austin and Travis County and has helped define Central Health's vision to transform healthcare delivery to Travis County residents. Now, therefore, be it resolved by Central Health that the Board of Managers hereby declares its sincere appreciation and gratitude to Senator Kirk Watson for authoring and passing Senate Bill 1350 and Senate Bill 1142. And these resolutions will be signed by Chairman Zamora upon adoption.
Do I hear a motion?
Mr. Chair? I move that the board adopt the written resolution summarized by Mr. Giesland and set forth in the board packet in recognition of the contributions made by State Senator Kirk Watson, State Representative Donna Howard, State Representative Gina Hinojosa, and Ms. Perla Cavazos, each of whom worked to advance Central Health's mission during the 86th Texas legislative session.
Now, correct, Mr. Chairman, we're going to read Perlis after the legislative
Oh,
members.
okay, so strike Ms. Perla Cavazos.
I'll
second.
Okay. All right, so I have a motion on the floor by Manager Bell, seconded by Manager Greenberg. Any discussion? All in favor say aye. Aye. All against say no, and motion passes. And again, I'd like to thank
Enter the passcode and
Yeah,
press
thank
the
y'all,
pound or
everybody,
hash
for-
key.
Yes, sure. Sandy? To make a comment?
Sure, Manager
You are the
Greenberg.
only
I just have
participant
one
in the
short
meeting room.
comment to make, and
Please
that
wait.
is thank you so much, because as we know, the system is set up to kill bills, not pass them. So thank you very much, we appreciate it.
We can do one at a time if you want.
Yes, do one at a time. One at a time. Yeah, do it in front of Central Health.
Yeah, I'm sorry you couldn't make it tonight. He was out of town, thankfully. Oh, sorry.
TMI.
I need my vacation.
And this is on the record and televised.
Thank you.
This is, your,
This is Lane, Representative.
right, yeah, no, but you also, this is
Mike, can we have a group picture?
Let him do this first.
Thank you. She's so sorry she couldn't be here this evening. She's at many other events. Still in town.
Oh, there she is.
There she is. Of course, happy to do it.
Thank you.
I think it'd be helpful, all of us, just one picture.
A picture of all of us?
Yes, the board
we do
and
that?
them.
Ask our photographer.
And here in front of Central Health, or where do you want us, Anastasia?
Yeah, right.
Come on, put her on the spot.
In the middle, probably. How do you want to, Anastasia? Renzo?
We're gonna have to squeeze.
We can squeeze in. We can squeeze in.
I'm gonna have to get close.
Yeah, we have to get very close.
Sandy, and Sandy's the tallest one.
Okay, that's fine. Ready, 1, 2, 3. 1, 2, 3. Thank you.
Thank you.
Thank you.
Yeah, of course. Thank you.
Thank you for everything you do. Yes, likewise.
So, I'll read Carlos, if you can make the same motion.
Ready? Yeah. All right.
Just recognize me again.
What's that?
Go ahead, I'm sorry.
All right, agenda item 3, discuss and take appropriate action on the resolution recognizing the contributions of Pedro Cavazos in advancing Central Health's mission at the 86th Travis, Texas Legislative Session. Mr. Giesen.
Yes. And, Mr. Chairman, if it would be appropriate, I'd just like to say a few words. Perla kept her cool, and she was the grown-up in the room. Every time something happened at the Capitol, she knew exactly what to do and who to call, and we are very, very thankful for everything that you've done. So personally, I want to thank you. In reading the resolution, a resolution expressing appreciation to Perla Cavazos for her service as the Vice President of Government Affairs of Central Health. Whereas Ms. Perla Cavazos has been a champion and advocate for the safety net healthcare system for Travis County, serving Central Health as Director of Government Affairs and now Vice President of Government Affairs. And whereas Ms. Cavazos has worked tirelessly as a public servant to create a model healthy community that improves the health of residents of Travis County. And whereas Ms. Cavazos successfully coordinated efforts on Senate Bill 1142 in the 86th Texas Legislative Session, allowing physicians working for Central Health to have an expanded ability to practice medicine. And whereas Ms. Cavazos successfully coordinated efforts on Senate Bill 1350 in the 86th Texas Legislative Session, allowing Central Health to establish a local provider participation fund in Travis County. And whereas Ms. Cavazos led the efforts to advocate for Central Health and other hospital districts, protecting resources and revenue vital to executing Central Health's mission. And whereas Ms. Cavazos brought tireless dedication to the people of Travis County, especially for the people who need access to health care the most. And be it resolved by Central Health that the board expresses its sincere appreciation and gratitude to Ms. Cavazos for her dedicated service to Central Health as Vice President of Government Affairs, and be it further resolved that the Secretary of the Board prepare a copy of this resolution for presentation to Ms. Cavazos.
Mr. Chair,
Manager Bell.
I move that the board adopt a written resolution summarized by Mr. Geisler and set forth in the board packet in recognition of the contributions made by Ms. Perla Cavazos, who worked to advance the Central Health mission during the 86th legislative session.
Second.
Okay, Manager Bell, seconded by Manager Greenberg. Any discussion?
Just,
Seeing
you're
none.
here.
Yeah,
Here,
unanimous,
here,
vote.
here.
Do a unanimous
Thank you.
vote.
Thank you.
Yeah.
Thank you, thank you.
All in favor? Where's the vote? Where's the vote? All those in favor say aye. Aye. Right. That motion passes. Thank you, Federal. You're a champion and a hero of mine. Thank you, everyone.
Thank you, Mr. Chair.
All right, agenda item 1, receive and discuss an update on key outcomes of the 86th Texas legislative session. Ms. Cavazos. Perla,
Perla, you're up.
you're up.
You're on deck.
She got all swept.
Session's over.
Sorry.
Time to go. Sign die already happened.
Lots of excitement tonight. Good evening, managers. Thank you so much for that resolution. That means a lot to me, but I do want to say that, working the legislative session takes a village, and it's not just one individual, but many individuals, including the staff who were here tonight representing their bosses, Senator Watson and Representative Hinojosa and Representative Howard. I exchanged probably hundreds of emails with staff, and I'm also really, thankful for our own Central Health staff that collaborated to make this a successful legislative session, including Mike and Jeff and Monica and Lisa and Katie Coburn, Holly. There was definitely, it was more than one person working to pass these bills. So with that, I'm going to begin this presentation. A lot of the first few slides you have heard, so I'm going to kind of, quickly go through them, and then I'm going to focus on the last few slides, which really what I tried to do is pull a few key bills that I think you would be interested in knowing. I tried to, of course, focus on the positive legislation that passed. But the last slide I did talk about some missed opportunities good bills that failed. And I updated the slide deck this afternoon, so I have updated PowerPoints if anybody wants. So it's more updated than what you were emailed.
Thank you.
So just a quick overview. As you recall, at the beginning of session, I came to you and we talked about how over 7,000 bills had been filed this session. Well, at the end, on sine die, which was May 27th, there were 1,429 bills that finally passed. And like Manager Greenberg says, legislative sessions are meant to kill bills. And so this is actually a record number of bills that have passed in recent legislative sessions. And then the governor's veto period was this past weekend, and there's 58 vetoes. I went through them today, and I didn't see anything that impacted us. There's a couple of health-related, but not anything that negatively impacts us. The key issues of the session, of course, you heard them over and over again in the news: tax reform and school finance. And in the end, the legislature did pass a significant school finance bill which basically will increase funding in new
new public education spending of $6.5 billion, and it's also meant to lower property taxes by $5.1 billion. And lawmakers estimate that, and this is on the school taxes, but lawmakers estimate that on average, taxpayers will get a 8-cent per $100 valuation savings in 2020 and 13 cents in 2021. But overall, I think it was a really good session. In terms of health issues, there were some missed opportunities that I'll talk about, but we had a really good, successful session, even though there were some, moments where I was really concerned, especially with Senate Bill 2, which I'll talk about in a few minutes. But as you know, Senate Bill 1142 and Senate Bill 1350 passed, and I do want to acknowledge Geronimo Rodriguez here with Seton, who also collaborated with the other major hospitals on Senate Bill 1350. So this was the bill that kept me up at night, Senate Bill 2. And overall, I mean, the good news is that we are exempt from the bill. We get to maintain our 8% rollback rate. But the bad news is, of course, that cities and counties are going to be capped at the 3.5%. And, I think this might be a challenge for us, because as we try to expand healthcare services, and so much of that depends upon partnerships with the city and county, there, I think, are going to be some lost opportunities. And they're right now in the process of looking at their budgets, seeing what can be reduced. Now, it's not going to affect this next budget, but it will affect the fiscal year 2021 budget. I want to talk a little bit about bills I was tracking for community care and the health centers. I was working with the Texas Association of Community Health Centers, and they had a long list of bills. In the end, these were the 3 bills that did get through. They were also tracking Medicaid funding, and I will say that Medicaid funding was included in the budget at the amount requested by HHSC, and it was actually an increase. So it accounts for caseload growth. Of course, they did not account for increased costs. Senate Bill 670 was a bill that we were closely tracking for the health centers, and there is more use of telemedicine, telehealth now. And last year there was major legislation that passed. This year there was a cleanup bill that just tried to clarify what health providers can be reimbursed for. And we were able to amend the legislation to include language that specifically clarifies that FQHCs can deliver services via telemedicine and get reimbursed at the encounter rate. So this is really good, and it should positively impact Community Care's budget. There was also House Bill 2261 by Representative Wally, and this was also important because this is legislation that reimburses physicians their loans. There was an increase from $160,000 to $180,000. And that's important because since this program was created, the cost of a medical education has increased. Lastly, I want to talk about House Bill 2425, and really what this legislation does is allows federal qualified health centers, their physicians, to delegate the ability to modify a patient's prescription therapy. It allows them to delegate that ability to the pharmacist, so the patient doesn't have to come back, schedule another appointment, to readjust the dose, then go back to the pharmacist. So it just saves time for the patient and money as well, co-pays. A few key bills that passed. In terms of medical and health professionals, the medical board was extended for another 12 years, which is a good thing, unlike the plumbing board. And so one note I made on that sunset bill is that TMB was asked to adopt expedited process for out-of-state physicians to come practice in Texas. Senate Bill 2011 by Senator Buckingham requires a study and report on streamlining physician licensing required for advanced practice registered nurses, which I think is also very important to the work that we do. It is, of course, controversial, so I think a study and a report is a good first step. On women's health, there were several pieces of legislation. These were the top 3 that made it. I think this is an area where there were lots of missed opportunities. There was also an increase to funding for women's health programs, so Healthy Texas Woman, family planning, the breast cancer and cervical cancer program. In terms of maternal care, most of the legislation was focused on that. So here we have Senate Bill 750 by Senator Colcourse, is just basically directing HHSC to adopt efforts to improve maternal care. And they did ask that the Healthy Texas Woman be closely considered in terms of developing a 12-month postpartum package. And that's important because there were several pieces of legislation this session that actually tried to extend Medicaid for 12 months for women who had a pregnancy under Medicaid, but all of those failed, and that was a missed opportunity. But this attempts to do something, at least within the Healthy Texas Women program. Representative Farrar passed a bill to direct HHSC to develop a strategic plan to address postpartum depression. There's also legislation that requires HHSC to just provide information who are auto-enrolled in the Healthy Texas Women program. Because a lot of women who are auto-enrolled, they might not know that they've been auto-enrolled, or they don't know what services are available to them. They don't know who the providers are. So this notice would even tell them who are the providers in their area that they could go to. Moving on, other key bills. In mental health, there was Senate Bill 11, which is a school safety bill, and a lot of it had to do with reinforcements to school campuses. There's funding for, metal detectors and security and that kind of thing. Fortunately, Senate Bill 10, which was focused on mental and behavioral health services for youth, was amended to that legislation, so I think that really improved the bill. And it's going to, one of the provisions specifically is going to allow child psychiatrists to be available for consultation with students via telemedicine. And then I wanted to give you an update on the Austin State Hospital. Senate Bill 500, which was a supplemental funding bill, did provide $165 million for this first phase of construction. So that's good. And this is the brain center that Senator Watson's been talking about for a long time. So $165 million, that's half of the funding that's needed to redevelop the Ash Hospital. So we expect that there will be another piece of funding next session. There was a lot of legislation on opioids and opioid addiction and addressing, providing, healthcare services and support around for individuals with opioid abuse and addiction. I was following this specifically for community care because that's something that Dr. Shasha is especially interested in. So these were 3 of the bills that I pulled, but there's many more that passed. House Bill 2174 would require electronic prescriptions for controlled substances and sets a 10-day limit. There was also a bill that creates programs and initiatives to prevent opioid addiction, misuse, and abuse, and there's one specifically targeted to mothers under the Maternal Mortality and Morbidity Task Force. This is the last bill before I move on to missed opportunities. I do want to say there was a lot of good legislation that passed. I was really pleased. I couldn't put everything on here because, we could be here all day. But I do want to, I'm working on a written report that has, more legislation covered. And so I'm happy to share that with you. Just a few things. The smoking age was raised to 21, so that was good for public health. And I know
Worked so hard
you
on
were,
that.
yes, you were passing. You were working on that. There were surprise billing reforms, which were, really great and a positive consumer step. There was legislation to provide transparency for prescription drug pricing. There was reforms to freestanding ERs. Also another, positive consumer legislation. This is my last slide. I just want to talk about a few missed opportunities. Unfortunately, some of the bills that I talked to you about early in the session did not make it. One of those was legislation by Representative Philip Cortez, and this would have provided a 12 months of continuous Medicaid coverage for children. Unfortunately, that didn't pass. Legislation, I already mentioned this, but several bills filed to extend Medicaid coverage for pregnant women from 2 months to postpartum, 2 months postpartum to 1 year. And, they got pretty far in the process, but ultimately they didn't pass. Manager Valdez, unfortunately, that Ortega bill that we were tracking had an interest in community health workers, using community health workers as part of Medicaid managed care. That did not pass. There was legislation to limit short-term health plans, health plan coverage for 3 months. A lot of those are not very consumer-friendly. That legislation did not pass. And then there was also some legislation to codify pieces of the Affordable Care Act, and unfortunately, none of those passed as well. You see those. Representative Howard did also have a good bill to add birth control to the CHIP Children's Health Insurance Plan. We do have an issue with teen pregnancies, and so unfortunately, those young women on CHIP do not have access to birth control. So that did not pass. I'm going to stop right there and ask if you have any questions for me. Again, I'm working on a more comprehensive report, and I'm happy to share that with you. Yes.
Thank you so much. We appreciate it. I think overall this was a good session. We've had some of our important bills passed. One thing that I'm really interested in, and perhaps with your report you can elaborate more, the relation between under Women's Health, Senate Bill 750, and Senate Bill 436 related to maternal mortality and morbidity.
Mhm.
And it's just not clear under 750 what are the variety of efforts to improve. I know they did not expand Medicaid post 60 days postmortem, but I would be interested to see what are those efforts, and I think those two bills are somewhat related to the same means. That's it. Thank you.
Sure. I'll take a closer look at that. Any questions? Yes.
House Bill 2425, is it clinical pharmacist or just pharmacist?
25. Oh, yeah. I don't have the answer to that question. You said clinical pharmacist?
Pharmacist versus pharmacist?
talking about PharmDs, or are we referring to just?
Clinical pharmacists versus pharmacists with the,
I can find out. There were two bills that did something similar. So one, they might be for the two different pharmacies. So I'll look that up.
Through all those?
And as a follow-up to that, because I was concerned about that ability for a pharmacist to be able to modify.
I wasn't concerned, I was just wondering which one, because some of them already have it, so I
Yes.
didn't know if it was extending them to the top of their licenses, or if it was someone else's, the other group.
And so then I guess my question is to you, what are they talking about, the ability to modify a patient's drug therapy? Because what were they talking about? Were they talking about increasing the dosage? You know, like if it's a 0.1 or
Yes.
a 1 to a point.
Modifying the dosage.
Increasing, decreasing. And the only reason I was, I guess I'll look it up or talk to you later, but what my concern would be is a lot of times you may have a difficult or reaction to an increase or a change in the prescription. And sometimes it's an immediate reaction, because I live with my daughter in that world, and sometimes it's over a period of time before you may get to a doctor. Our challenge has been sometimes ending up in the emergency room because she's having a dystonic reaction to a change in a drug, or the amount. So I was just curious how they were gonna be handling that, and if anybody was gonna be tracking adverse or negative reactions to that.
I can
I'm just
I can
curious.
look at those details.
Okay.
Ram?
Wouldn't the physician be tracking, the clinician, the adverse effects of a medication? Wouldn't that be reported to them? Just
This is in
as a,
between. If they have a negative reaction, sometimes we would be immediately in a hospital. Sometimes we wouldn't make it out of the doctor's clinic, and we'd have to go straight to the ER in the same hospital.
Okay, I'll try to see if I can find out more about that specific
Maybe just
question.
if I may, just while you were asking the question, I had the opportunity to pull it up real quick, but literally, it takes existing statute that applies to hospitals, for instances, and just drops in FQHCs, and so I don't think it creates any new law. But it does make reference to certain protocols that have to be followed, so those are gonna be standard of care type issue things that are already in place.
Thank you.
Thank you, Mike.
Any other questions? If not, I got one statement, or two statements. One, thanks to the representatives and to the senators for extending our TMB to another 12 years. Our TMB is probably one of the strongest in the country. It really protects our patients. It's not protecting about patients, it's not protecting physicians, but it's protecting our patients to make sure we have the highest quality of service we can deliver. And it also, because we have tort reform, allows us to bring in more physicians, because we need more physicians and providers and nurse practitioners to the state, so we can have enough so the patients don't go unseen. That's my first statement. Second statement, I'm gonna look over to my colleague, Dr. Bell. Didn't we have birth control pills on the P&T committee when I was serving on the P&T committee? I thought we did.
No, it's never, I think,
Never priced.
Manager Aiken?
Manager Aiken, did you have a question? No?
Okay.
I thought we had, okay, sorry, my fault, that was a long time ago, I guess. Bella, thanks again.
You're welcome.
Thank you for everything you
Thank you.
did,
Gracias,
and
Bella.
all the staff,
Thank you.
all the staff's work.
Yes.
Thank you.
To you and the team,
Yes.
and your collaborative partners.
Extended
Elsewhere,
family.
that's right, elsewhere.
So this is just an informational item, no motion is necessary. Agenda item 4, receive and discuss a presentation on the fiscal year 2020 budget and the financial forecast for subsequent fiscal years, which presentation will include information on possible property tax rates to be assessed. Lisa and Jeff? Jeffrey, just you?
Thank you, everyone. Lisa Owens. I will give an abridged version of the longer presentation that we gave at the Budget and Finance meeting the other night. But we went through in great detail about all the changes that we are facing in 2020. Perla also just mentioned some of those legislative changes that are there at the bottom. But we also, as Jeff went through last Wednesday, in detail have seen a lot of financial funding changes from our uncompensated care to the payment model. So with that year of changes, we prepared a 7-year financial forecast this year, which gives a longer view of many of the unknowns that we have in the financial forecast. But I would just like to remind you that this is a tool for the board to look at that longer term outlook, as well as provide guidance to the staff in order to use a starting point tax rate to prepare a draft budget for you, which we'll bring back later this summer. So it is a tool that we use it's the first step in our budget, and it is the tool that the board has used in the past to help look at a starting point on a tax rate for the budget. So just to hit the two scenarios that we provided, the longer term models we provided to you on last week at the Budget and Finance Committee, were a 7-year look, and again, looking at the longer term in this case. At the very bottom, you'll see the days of cash on hand, and we've talked many times about trying to stay at or around 100 days of cash on hand. But also, you'll see in this forecast, which has 6% over our effective rate for 2 years, so next year and 2021, and then lowering to 4.5% thereafter, so the remaining years at 4.5%. You'll see that in 2022, uses are greater than sources, and that has a negative impact on our reserves, and those decline over the term, showing that in 2026, very low cash on hand. So the next model that we prepared was a 7-year forecast with an assumption that there would be a 6% effective rate on an ongoing basis in each of the years. And as you'll recall, that does get us in a much better position in 2026. You'll see that the sources and uses are almost equal, achieving that structural balance. And then you'll see that there's a slight turn and the trend upward in our days of cash on hand between 25 and 26, which is what we would be looking for as we start to stabilize or rebuild those reserves after the many changes that we know are coming in 2022 and 2023. And then for this evening, we did prepare one more model based on the conversation from last week, as well as considering what the impact could be to the organization if there is legislative action next session that could limit hospital districts or Central Health's ability to increase our percentage over effective. So we looked at an 8% over effective for the next 3 years, and then 3.5% in those out years, which would be after the next session. And you'll see, again, this model in the first few years where it is at that higher level of 8% over effective does help increase the reserves, with the peak being in 2022. But then that cap of 3.5% would very quickly start to see the trend down and not recover in the longer term, as our uses are greater than our sources in these longer term models. So we wanted to just prepare an option for you to look at that had that a slightly higher effective rate over effective, and what that could look like if legislation does impact our organization in the next session. So as far as next steps, I don't think we're posted for action, but the Central Health staff does plan to bring back a draft budget to you. And we would plan to prepare that proposed budget at a property tax rate as a starting point of 6% over effective, as it has that second model that we looked at. We would do that in order to achieve the priorities. The uses in the budget would achieve the priorities in the strategic work plan, and we would bring that back to you later this summer, prepared at that 6%. And then we would also recommend that if we do have an agreement that comes forward this evening, I think in a later item, where an agreement is made with social finance for the permanent supportive housing and wraparound services for the homeless Travis County residents, that Central Health staff would then prepare a budget to include that $600,000 a year, and calculating what that would just be 6.3% over effective. And that each 1% over effective is just over $2 million in the next year's budget. So we looked at what would we have to increase the property tax over effective to get to that 600,000. It's just at 6.3%. And that would be, again, we have our calendar. We're here this evening, June 19th, and we have many more meetings to come leading up to September when we hope to get our budget and tax rate approved by this board and the commissioners. So I will answer any questions.
Thank you, Manager Valdez.
Thank you very much, Lisa. I appreciate it, you and your staff, Jeff and everybody else. I have I'm just curious, because I left early last week, Budget and Finance meeting, and I was wondering if it was, how difficult would it have been to do something like 8%, like the third forecast here, the 8% for 20 through 22, and then a 6% thereafter.
We can run that for you.
I would just be curious to see, and the only reason I'm taking that in consideration is because I can't imagine unless there is a significant change in the legislature, I can't see our collaborative entities, taxing jurisdictions, being able to contribute anything. So if we are going to look at addressing the needs of our community in a collaborative way, to take that into consideration, then we should be prepared to also understand the limitations that they would have to contribute to what needs to be done to accommodate the needs of our patients. So that's our community, yeah, so.
So
I would-
8%
yeah.
for 3 years and then 6%.
6%
Okay.
thereafter. I just can't see the significant change and I think that we do, in an overall, using that overall lens, we really do need to look at that, so.
I have Manager Bell and Manager Greenberg in the queue. Manager Bell.
Can you remind me, what was the rate that we set last year?
6% over effective.
6%.
6%?
Mhm.
Okay, thanks.
Manager Greenberg.
Thank you for that presentation. Looking at the forecast in front of us, 6% is the one that would allow us to accomplish the goals that we have set forth and the commitments we've made to the community and initiatives such as in the Eastern Crescent, is that correct?
Yes.
Okay, and it would also allow us, according to what I see in front of us, to return to financial stability, is that correct?
Yes, you'll see the structural balance
Yes, I
that
see
comes,
that.
where the lines come
Right.
together in sources over uses.
Well, that appears to be a good starting point to me. Thank you.
Did I see your hand, Ron?
Yes.
Manager Musaitis.
Thank you, Sean. Thank you, Lisa. Appreciate it. As much as I hate going higher, I would personally recommend the 6.5.
Okay.
Because right now giving other entities are capped and they may come to us in the future for any additional services or something may come along the way. I would like to have some more cash flow in hand to give us more flexibility to do that work. So that's my recommendation.
Thank you, Manager Musaitis. Manager Jones or Manager Zuniga, any questions?
Just two quick ones. One is, I echo your concern. I think that if we were to get in that situation, our planning efforts need to be more engaged with particularly local health agencies to make sure that we're all on the same page in terms of those strategies to do that. But I concur with you, given our unique opportunities to continue at the same rates we have. So I applaud your comments on that. The second question is, and it's really in our next discussion, I think, is on the social finance. Help me understand, this year, it was my understanding, we had funding identified for that. Would that not automatically carry over until next year, or was this special identified funding for that purpose?
The funding that was identified in this budget was called New Initiatives. And so we would need to continue to budget for that. It would become part of an ongoing
Okay,
program if it's a
so
longer-term commitment.
We shouldn't assume that the new initiative money would automatically carry over to next year, okay.
Let me just ask Manager Akins, are you done?
Yes.
Thank you, Manager Jones. Manager Akins, any questions?
She said she's good.
No? Okay. Manager Musaitis.
Thank you. Well, following up like, what you just said, Mr. Jones, and I think we're both public health strong advocates, here. And I've heard and learned from our officials that there might be some, public health services, delinquished because of the cap. And I feel as we are the hospital district in this community, we need to take some of the ownership. And that's why I would hope that we work, Perla is here, and I think we're also planning on meeting with some city officials in the upcoming months, that we look into it, and our county officials as well. Where can we fill in the gap? So our continuum of care is continued. So some of the services that are meaningful and for our community still can exist. And we are in an authority to maintain that source of funding. So that's what I just wanted to present that.
Thank you.
Any other questions?
Just one clarifying question. On this allusion to, you alluded to the social finance agreement and you having the 600,000 per year. I just wanted clarification. That's 300,000 from us per year and 300,000 from from the CCC.
Correct.
For,
Thank you for
per year.
pointing
So
out,
we
yes.
would be giving a total of 600,000
Yes,
for 5 years.
yes.
That's the commitment, okay. That's $3 million.
Manager Bell?
Lisa, did you get the guidance that you need on what you're gonna work on? I heard 6.5, I heard 6.
Yes, I think when we come back with the budget, one thing that we can bring back is that incremental revenue that would come with different rates. And we've done that in the past,
Right.
but this gives us a starting point to prepare a budget. And then, as I mentioned, based on the preliminary numbers that we have on the assessed values of new construction, which is what drives the revenue,
Right.
we currently estimate that to be about $2 million per percent, just over $2 million. So we can work with you in the budgeting process to determine if you'd like to change that later. But thank you.
Lisa, thank you. Agenda item 4 was just an informational item, no action is necessary. Agenda item 5, discuss and take appropriate action to create a healthcare provider participation program to be administered by Central Health, which program will result in establishment of a local provider participation fund pursuant to Chapter 298E of the Texas Health and Safety Code. Mr. Canola. Jeff?
Oh, thank you. Jeff Knoll, CFO. We did a in-depth presentation last week at Budget Finance related to this item for informational purposes. We are coming back this evening to request action to create the local provider participation fund related to some action that Central Health, HHSC informed us on. Probably the day before the meeting, so we are working in real time related to creating and eventually establishing the rates related to the LPPF. So tonight we're asking for simply creation. We have a resolution related to the creation, and we're requesting action related to that. So we've talked a little bit about the creation of the legislation around Senate Bill 1350, which grants the Central Health the authority to participate and create an LPPF based on an affirmative vote of the board. As I mentioned, we had some recent developments around HHSC and around specifically the filing of what are called affiliation agreements. And these affiliation agreements are agreements that need to be filed with HHSC no later than July 15th. Our board schedule next month is, our board meetings are the latter half of July. I think our board meeting is actually at the end of the month. So we're here today to request action to establish the LPPF so that we can meet the timeline to file the affiliation agreements that will help us qualify for the
September uncompensated care IGT payment that's, I believe, due to be sent September 5th. And again, in that notification from HHSC, they notified us that the program needed to exist in order to follow the affiliation agreement. That wasn't necessarily our understanding before that call, so hence the accelerated timeline and kind of the multi-step process we're going through. So speaking of multi-step processes and timelines, this lays out what we expect, the actions and the events that we expect related around our LPPF. It may be a little fluid in August, depending on the information that we get from HHSC. But we're here today, June 19th, to authorize creation of the LPPF. Pending that action, assuming that action occurs, we'd move forward with working on filing the affiliation agreements with HHSC by July 15th. We would come back to the Budget Finance Committee on July 24th and do another overview related around setting the rates that the LPPF will administer, that set the payments that the hospitals will make to the LPPF. We'll come back on the 31st to actually set the rates and to conduct a public hearing related around setting those rates. And so that would wrap up the events related around what's called Demonstration Year 8 or Fiscal Year 19, which is the current fiscal year that we're in. And then we would move forward to setting rates related to fiscal year 20. We're trying to correlate that as much as we can in the budget process so we don't set up unnecessary meetings related around that action. But we would go forward and have a rate setting process that would set the payment rate for fiscal year 20 or demonstration year 9. We would have a public hearing prior to that. And then ask for that consideration in setting that rate, and then moving into fiscal year 20, we would assess that and collect the funds related to the local funds for the programs that the LPPF would be participating, the supplemental payment programs the LPPF would be participating in. And then last but not least, but it's a little out of order, is related around the July 31st rate. We would set the rate, and then on September 5th, we would actually have or at least the schedule currently, the intergovernmental transfer for the final uncompensated care payment is scheduled for September 5th. And so the LPPF would actually would have at that point collected the funds or the payments from the hospital, and then they would transmit those local funds in order for those matched funds to be sent to the appropriate facility. So with that, let's see, we went over a number of things last week. With that, I'll stop the presentation.
Got a motion
Again, I'm
on the floor first.
requesting action today to establish the LPPF, and I'll be happy to answer any questions.
We're gonna get a motion on the floor first, Jeff.
I move that the board approve the resolution as set forth before us to enable Central Health to create and participate in a healthcare provider participation program to be administered by Central Health, which program will result in the establishment of a local provider participation fund as contemplated by Chapter 298E of the Texas Health and Safety Code.
I second.
Okay, so I have a motion on the floor by Manager Greenberg, seconded by Manager Aldes. Let's have discussion now. Manager Aldes.
I just want, with respect to risk, I just want to hear maybe, or have you re-clarify that if a hospital asks us to send money up, they give us some money, we leverage, we send it up, and they don't complete apply. They don't get the outcomes that they expected. At that point, what happens?
Could you clarify what the outcomes might be?
Well, okay, so
It's a-
here's,
well-
we're gonna be ITT.
Well, let me
Okay,
answer it
let's
this way.
start from the beginning.
It's a pretty mechanical process.
Yes,
So our role is, we have a fiduciary type role in this process. So we simply collect the money or the payments from the hospital, so we'll have to figure out how to do that.
right,
We segregate those funds in a separate bank account,
right,
and then based on the participation of the programs that the LPPS participating in, we would send the money up for whatever applicable funds are matched. The state and the federal, so the federal government matches it. Those funds come down to the hospital based on some predetermination that Central Health has nothing to do with.
right.
So there is no, we do not determine where the funds go. And, you know, we talked about moving into next year, how there's a allocation based on the Medicaid SDA.
Right.
So it's all somewhat of a mechanical process, probably on both sides, but we would not control the outcome
No,
of how
no,
the funds flow.
I think then, let me clarify, because I understand all of that. I just wanna make sure that we as the administrator, at no point in time, let's say next year, because then each of the hospitals would have then determined what it is that they're going to be doing, I'm assuming.
Well, it's
correct?
really more of a uniform
Yes,
process.
but each hospital, or each county, or each entity is not going to be doing exactly the same thing. They're gonna be doing what it is that they need to do, or have determined that they're going to do for their particular community. Is that not correct?
That's true.
Okay, so let's say Hospital A, BCD, where the 7 that are participating, says that this is the plan, this is the program, this is how much it's gonna cost. We get the monies back, it goes directly to them, or, you know, it's gonna go to each and every one. If one of the entities does not follow through, complete, whatever word you wanna use, that particular, whatever it is that they set out that they were going to do, we will not be held responsible for them not completing that
So it's
program.
again, it's a pretty mechanical process, not
just wanna make-
predicated on what services a hospital may or may not provide. It's simply a mandatory payment rate
That's great.
that all of the participants in the Travis County LPPF, they pay the same rate. It's a rate that's a percentage of net patient revenue. And it's a uniform rate across all the hospitals. So everyone pays this, they won't pay the same amount because they'll have
Right.
different net patient revenues. But the payment rate itself is uniform across all the hospitals.
Okay, I just wanna make sure that we're not gonna have any risks.
And
That's all.
Freeburg.
Not only are we not going to have any risk, but it is totally mechanical. Unlike DISRIP, there
That's
are
right.
no outcome measures to be achieved or anything like that, correct, Jeff?
Well, there may be some program
Right,
requirements,
but not,
but it doesn't impact us. We're simply
Exactly.
a medium transmitting
Exactly.
local funds.
I was
Exactly.
talking about the program.
right.
Thank you. That's- I'll move forward, let's go.
Any other questions? All right, let's take a vote. All in favor, say aye.
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 All against, say no. Motion passes. Any abstentions? Okay, motion passes. Oh, but how did you vote, Abigail?
Abby?
I voted yes. I
Okay.
unmuted myself. Hopefully you heard me.
Okay.
Thank you, Abigail. All right,
Thank you.
thanks, Jeff.
Thank you.
Agenda item 6, discuss and take appropriate action on the interlocal cooperation agreement between Central Health and Travis County for collaborative health planning. Megan.
You get to see you, Maria, at the table.
Right, man.
She'll be presenting. Thank you. This is an interlocal agreement that has been in place since 2015. It's actually an interlocal agreement among Central Health, Travis County, and Austin Public Health. It really formalizes our relationship to collaborate, to share our data resources, and to organize our programmatic and planning efforts around social determinants of health and critical health issues. Central Health serves as the fiduciary agent. So we have one interlocal agreement with Travis County and then a separate one with Austin Public Health, but they're matching budgets and matching scopes of work. The total budget is $20,000 and each partner contributes about $6,600, a little bit more. We have, like I said, we've had this interlocal in place since 2015. I believe we were out of renewal options, which is why we're presenting it tonight. So we hope that you'll execute, I guess, a new interlocal agreement with 4 options to renew so that we can continue our partnership.
Can I hear a motion? Can I hear a motion?
Yes.
I move that the board approve the execution of an interlocal cooperation between Central Health and Travis County for collaborative health planning.
I'll second.
I have a motion by Manager Jones, seconded by Manager Musaitif. Any discussion? Manager Musaitif?
Well, thank you to my favorite people. So can you give me more details about, I think you said 4 options? So what are those options?
Just 4-year renewals, so that this will
okay.
continue our partnership until, what, 2023?
So can you give us more what this partnership has yielded? What are the successes?
If I may.
Yes,
I think one of the essential things that, results and outcomes that,
Ma'am?
sorry, my name is Ana Almaguer, I'm Travis County Health and Human Services. Thank you, Sharon. I think one of the results that have come out is that, we are all taxing entities, and so we can leverage resources better, and we are all looking at data about the same individual, sometimes in a different angle. So it really helps to put it all together and come up with a better sense of the needs and issues being faced by our residents.
So as right now, when our budget proposal for next year, I think I'm all about collaboration and trying us to fill in the gap. So with your partnership here, can you somehow present to us where's the gap that it's the county or the city's trying to cut in terms of health that maybe Central Health can come and intervene? Would this be something your partnership can bring forth to us?
Neighborhood profile.
We do have some data. So this past year, we've been working to take a deeper dive at census level into some neighborhoods in the eastern Travis County Crescent. So I think we do have some of the analysis done. But in respect to, are you talking about the tax cuts?
Yes.
I think that's something our group could look at, but we have not looked at with that lens
Not just
yet.
because it's, you're convening this partnership and it's
Absolutely.
something that we need to all be aligned. I think as Mr. Jones had previously mentioned.
I had
Thank you.
previously mentioned.
Manager Valdez?
Ms. Valdez as well.
I mean, I noticed that it said the partnership, or y'all had discontinued the service in 2018 due to rising costs. I understand that, but y'all were continuing to collaborate regardless of the discontinuation of the of the
Data portal,
the data portal and the website.
yes. That was
Okay.
one tool that we used in our partnership and that we discontinued.
Okay, so that was the only tool that was discontinued? Because in reading this, it's kind of maybe not clear what was discontinued when it says it was, the partners discontinued the service, and I thought it was just for the data pool.
Just for the data portal.
Okay, so with respect to the collaboration, which is how we all should be working together to share data and better plan strategically so that the budgeted amounts will not be borne by any one entity, but rather shared in a collaborative manner. Are you going to be talking to the CCC with respect to this as we as we, look at the information that's being gathered in the, is it the IDD or the IDT? Where's Jeff's gone? The IDS, that's, the IDS, the,
Brought the CCC in at our last meeting, and I believe it's our intent to
to be
fold them in.
a part,
Mm-hmm.
well, y'all should be one and the same. I was just trying to see how that was gonna be different or distinct from what it is we have talked about, within the enterprise and under the IDS. I guess it's the IDS, Monica, that I'm trying to think about, where we're gathering all the data from the ICC, from the city of Austin, from the county, from everybody else. This is what I thought we were actually doing already.
So this information, as Megan and Anna both said, this,
Hey,
this, Monica Crowley, Central Health, this group has already been, in place since 2018, or 2015, sorry, 2015, 2018 was when the Healthy ATC went away. But, the data sharing from this group already is shared with folks at the CCC. The information that the group looks at, kind of initiatives and looking at information, is integrated into the work of the CCC already, and, has been, for at least the past year. So I think that will just continue. I think that what, Megan and Anna are talking about is the work of this group in sharing data and collaborating together on things like, I think one of the indicators that the city and the county has is, mortality information. So sharing the information that the city and the county has with the information that we have with Central Health and the CCC, that this is just work that's part of our workflow already.
Yes.
And that we want it to be able, to
We're just
continue.
reinstating the
Yes.
financial, commitment to this so that it can continue. That's clarification of, thank you very much. I just wanted to know how we were, melding it with the IDS, because we've made a big financial commitment to the IDS and to the gathering of that data so that we could better plan strategically. Thank you.
Manager Jones?
Yeah, I want to commend, having served in part of that role, I want to commend the work you've done, especially Anna for her leadership and her collaborative effort for all three agencies. I just a little word of encouragement, and I've said it several times, that the data, that particularly the epidemiological data that's available, to be able to overlay it with the social economic data. I've seen, and to JP's credit, he's putting it side by side. But people are visual people, and I think it's very helpful to be able to see that the lower socioeconomic communities are here. The people who are dying, who have greater disease, are in the same area. And the people who are dying, for the most part, in the same area. I think that's a very strong argument to make. So from a visual point of view, and a marketing point of view, and an outreach point of view, I think it's important. So I'd encourage you all to consider developing some tool to be able to do that.
Okay, thank you. We'll look into that.
Manager Presente?
Just one last question. Is there any hopes or plans for bringing back Healthy ATC?
So the city just purchased a new data tool, and I think it is our plan to figure out how the three of our entities can best promote and use that new data tool.
Thank you.
Abigail, any questions? No? All right. No further questions?
Just one comment. I know previously, a few years ago, one of the things that I asked for, this very thing is what I asked for, and I remember I was using that as an example. We have the base layer, and then we add on the housing layer, we add on the jobs layer, we add on the blah, blah. So you would eventually have a layered map, but you could easily take off, and we would have it. And thank you. I just have to say thank you, because it's always nice to know that great minds think alike. And I can thank y'all, because we're finally realizing that request that Sherry and I worked to make sure would happen. Okay, thank you.
Seeing no further discussion, let's take a vote. All in favor say aye.
Aye.
All against say no. Any abstentions? Motion passes.
Thank you.
Thank y'all. Thanks, Megan. Thank you, Anna. Agenda item 7, discuss and take appropriate action on the use of new initiative funds during fiscal year 2019, including the agreement with Social Finance, Inc. and its subsidiary Path LLC for permanent wraparound services to be provided for the to homeless Travis County residents. I guess read 10 also together, Holly?
Actually, let's start with 7.
Okay.
And then when we decide to go into closed session, I'll have you read 10 and we'll take this up together.
Okay.
If you don't mind, I'm going to stay in this seat because I have a lot of materials. But the reason that we are back tonight is Mike and I had a meeting with representatives from Social Finance on Monday this week. And in your backup for this evening's meeting is a written summary of what was discussed at that meeting. We primarily focused on the 5 conceptual terms that the board put forth in a motion at the Budget and Finance meeting. And the material Social Finance provided goes through which of those terms they have agreed to and which of those terms they're offering a sort of counter proposal, so to speak. And so after we finish going through this, we have a couple options. If you are in favor of moving forward, despite the fact that there are some terms that are different than what were proposed to you last week, we will have to take an action to amend the previously adopted motion. So that's the first step. Then we would have to make a further motion to agree to allow Mike to execute an agreement on terms similar to or more favorable than those we presented. So I just wanted to give you the lay of the land before we dove in. So I am looking at the backup at page 101. And I wanted to say thank you to Social Finance because one of the things that they did that's going to make my presentation very easy tonight is they reproduced the proposed conceptual term and then they put their response right underneath that. So thank you very much for that. So looking at proposed conceptual term 1, you'll remember that this was a term that required Social Finance to seek the consent of our social impact investors to disclose their identity and the deal terms within 1 week after the financing agreements are executed. And then Manager Oliver asked, and the board agreed, that we would also be able to terminate the agreement without penalty if we did not get that information. Social Finance has agreed in spirit with the concept of this, but they are proposing something slightly different, which is that they will get from investors the name of the institution, and they will disclose that to us, and the investment amount. And those disclosures would be made within 1 week after financing agreements are executed. But because they are going to affirmatively get those types of information, that there not be a clause for termination of the agreement, because they will provide those data points to us. So that's the first proposed term. The second proposed term was our provision that would cap the return to investors at no more than 6.4% of the investor's investment. And so the counter proposal here is actually set forth on page 102 at the top. It's underlined. And I don't want to discount the explanations provided before that, but I'm sure you've read it. So the proposal is to cap the investment return at 9% and to increase the amount of outcome payment for emergency department utilization from $128 to $138. So a $10 increase in what Central Health would owe if a successful outcome were achieved, and a 9% total return to investors.
That's times the what, 250? I mean, depending on the number of ED visits.
So there is a complicated formula that Social Finance could probably explain to you a little bit better than me, and if it's the prerogative of the chair to recognize Social Finance, if you want an answer to that question.
Sure. I'll let Holly finish first now.
Sorry, I apologize.
Moving on to conceptual term number 3. This was the term that would allow
advantageously on our own to terminate the agreement, without penalty. And so what you'll see here, and again, if you recognize social finance, they're welcome to correct my misstatements, that they believe this right already exists under the current agreement, and that if we, upon further review, feel more comfortable, they would be willing to add language that allowed the payers to collectively terminate and fund the project directly. However, one of the things that we discussed on Monday was that the payers weren't just the governmental payers, meaning the city of Austin and Travis County. It would also include the other payers like Seton and HUD DOJ and Episcopal Health Foundation. So we're talking about a much larger group of people that would need to come to an agreement on this item. And I think we still would like to see what the total cost to us would be, because there are some project costs that I think social finance would like us to pay under this option. So number 4, a provision that prohibits social finance or any other payer from seeking or using funds that Central Health deposited for project costs unrelated to medical care. And so I think, as I just mentioned, I have been looking through the agreements. I have been probably not as thorough as I would have otherwise been if I had a little bit more time, but I haven't been able to find a definition of what project costs are. And so I think that the response we received from social finance is here on page 108, top of the page, that says payers will be responsible for making their pro rata share of payments to cover the cost of services rendered. And I don't know if that includes project costs, what project costs encompass, and also how easy it would be for us to separate the wraparound services into those that are purely medical or hospital related.
Right.
And then finally, provision 5, this was a provision that obligated PAC LLC, which you'll recall is a subsidiary of Social Finance and who will actually enter into the agreement with, to ensure that 60% of project participants are enrolled in the medical access program. And so I think that, again, the spirit of this provision or conceptual term has been addressed by social finance's response. So now in the agreement, and specifically Schedule 1, would say what is here in the italicized language, no more than either 82 total program participants or 33% of total enrolled program participants. That was the old language, I'm sorry. The new language would clarify that at least 66% of total people enrolled in the project would be MAP enrolled, MAP eligible, enrolled sliding fee scale patients, or eligible sliding fee scale patients. So that is what I have to present at this moment. We'll have some more to talk about in closed session, but I think it would be a great time if we want to bring social finance up to do that.
Thank you, Holly. Will you please come up? Come up. And just for the public record, would you state your names?
Good evening. Nirav Shah, Vice President in Social Finance.
Hannah Jamal, Director of Social Finance.
Do you have a question of Manager Valdez?
Yes, I'm sorry. I was trying to take care of my daughter through the phone. With respect to, what was it I was asking about the page 1, oh,
Page 2 of 3 on our.
yeah, page 2 of 3, I think she has 102, but,
Yeah, 102.
so I was asking, I guess what I needed was clarification as to what the formula is for, you know, with respect to the development of the project, okay? And I remember that when ECHO was here, I mean, you know, Ann Howard, they were talking in terms of how they had some kind of information or data that showed about how many, within this population, how many ED, they did know how many ED visits there were with the profile of the patient that they were gonna be looking for. What was that amount? I don't remember.
I believe it was 16 for the top 250 individuals on our list.
16 per year?
Per person.
Per person?
Oh, sorry, 18 months. 16 ED visits over 18-month window per person.
Okay, I'm not a big math person without using a calculator. So what does that translate to? So, and with respect to that, the change of $10 increase for each of those ED visits under the project, the proposed project is what we're talking about.
So the way the payments work on this project, it's all relative to the reductions in ED visits created. So the payment formula would be the percent reduction in ED multiplied by 100. So you turns the percentage into
I just want to know what the bottom line cost is going to be.
well, it's all
Ballpark to
relative
us.
to the outcomes created. So if we reduce the ED visits by 10%, there's a different payment, versus if you reduce ED visits by 50%, there's a higher payment. So there are lots of different payments. They're all based on relative to the amount of reduction in ED visits.
And that's outlined where?
That's outlined in the contract and is also outlined in the PowerPoint presentation we shared last time that I believe was in the backup
So
of
somebody
the-
has seen the contract, we have not,
I have the contract and
Okay,
some
but
staff
we
has
have
seen
not
the
seen that.
contract.
correct? Am I just
Correct.
assuming, yes?
Correct.
Okay, so I don't know what all the contract language looks like. And with respect to then, thank you, I appreciate that. On the next, item number 3, with respect to the definition of payers, is there, you're citing and putting the private corporations in the same level of, is that the same level, the same definition of payer as opposed to what was a proposed conceptual term? And that was just the public entities as being payers? And your response to that was, I'm just trying to get it correct. Your response to that was, well, a payer's a payer, regardless of whether you're a private corporation making it, or a public entity? Is that what I was, the gist of what I was understanding?
We're using the word payers to mean the organizations that are agreeing to pay a certain price based on measured changes in outcome. So if ED visits or inpatient days are reduced, there is Central Health, the Community Care Collaborative, Episcopal Health Foundation, Ascension Seton agreeing to pay certain outcome. So those are the payers that we're referring to with specific to the health outcome metrics.
I guess what I was looking at was specifically was the definition of payers. Was there going to be a definite, is that, did I not understand you to say that, Holly, I'm sorry, excuse me, I'm not gonna ask to rerun the tape, I'm just gonna ask for clarification from you, because you were the one that was explaining it to us, that their response was that they're more payers than just Central Health, City of Austin, and Travis County. You did say that?
I did say that that was part of the discussion we had on Monday.
And that it was all-inclusive then?
So the.
Is that what I understood?
Yes, I think that is your understanding, and I think that is correct to what I understand.
Okay, but, well, let me just clarify. The only reason I'm asking for clarification is because the public entities were not going to be getting any 9% or 12% or 6.4% rate of return on their investment. Is that correct? Am I understanding this correctly?
Yes.
Mike?
Correct.
Sure?
Yes.
Okay, so that's why I was kind of more amenable to having them in a different category of payer as opposed to every payer is the same, because they're not all the same.
I think there's conflation of payers and impact investors.
Yes.
The impact investors are putting up money that will provide services to 250 individuals over a 5-year period.
And they're putting that money up front in an account that is going to be used, or they're not?
Committing
Okay.
$16.3 million over 5 years. It will not put all $16.3 million in an account in day one. It'll be drawn over 5 years. And they're eligible.
I'm sorry, did you say they will or they will not?
They will not put the $16.3 million in an account in day one of the project. It'll be drawn over a 5-year period. And they're eligible to get up to a maximum of 9% return, and they're also eligible, they could lose all of their money, 100% negative return.
Then we won't know that till after the project's
After
completed.
the outcomes are measured, yes, ma'am. And the payers are the organizations that are funded. paying for positive outcomes only to the extent they're achieved based on the terms in the contract. Those are the City of Austin, Travis County, Central Health, Community Care Collaborative, Episcopal Health Foundation, Ascension Seton will come in through a grant, and then HUD DOJ. And just to go back to Holly's point, we are open to a discussion on having just the 3 public entities, City of Austin, Travis County, Central Health, to come in and say, we can do this more advantageously, I believe is the language that was put into the memo. I will just call out that that means the money contributing from the other payers will not be contributing that amount of money if the contract was terminated and the other entity decided to pick it up.
Okay, I appreciate that clarification.
Ron? Ron?
Are you
Go
done?
ahead, go ahead.
Thank you, Chair. Thank you. Thanks for being here again. I appreciate the work that you have done and this thorough memo. It's quite helpful for us, for everyone. My question is, all the pairs, are they gonna have the same rate as us? The proposed 9%?
Correct, so all of the
it's,
payers will be universal,
Okay.
meaning the investors' returns will be capped at 9%, and that will be uniform across all the payers. So it's not as Travis County will have a higher cap versus
Okay.
Central Health.
Wonderful, I just wanted, and under 4, this might be a Holly question. So when we're talking about unrelated to medical care, like for instance, is social work part of our expense or not? I'm just, can you clarify that?
Yeah, so actually I would really like to have that discussion in a closed session. But that is one of the things that I pointed out and you listened very well, which is it's hard to separate out what is impacting the medical and the healthcare outcomes.
Okay. I will leave it at that. Thank you, and I look forward for this project to move forward.
Manager Greenberg?
I also had a question on number 4 that we'll address in closed session.
Right.
But going back to number 3, so what I think I'm hearing is if we were to say limit this under a termination to a takeover and completion of the project to just the 3 governmental entities, being the city, the county, and Central Health, then we would not have at our disposal the money from the others being
Investors.
not the impact from, say, who are the other 2?
Episcopal.
Episcopal and
HUD DOJ and then
Ascension Seton.
Ascension Seton.
we would not have that money available to us to complete the project. Is that correct?
That's correct.
Well, so may I respond?
Yes, please.
It depends on what we are able to negotiate. And so at
Okay.
a minimum, if it's the 3 governmental entities, yes, that is correct. However, if we were to bring along the other foundations, St. David's, Episcopal
Right.
Health, then we would have the benefit of that.
So I don't know, and Holly, tell me if this is something that we should discuss in closed session, but I think we somehow need to discuss if that were to occur, what is most optimal for us at Central Health. Whether we include them, whether we include only part of them, whether we have an option to include them. Is this a discussion for closed session, Holly? I assume that it was. And I have another question related to that, and Holly, that it may also be one for closed session, but it is, what would the cost to us at Central Health be if we were to terminate and take us over to complete? And I assume those costs are going to vary according to my prior question as to who all's included.
I think so, but one thing that I know I'm not allowed to ask questions, but it would be useful to hear what social finance believes the cost would be for those payers who decide to exit and.
Then I would like to hear that, please.
Yes.
Sorry, can you repeat that?
So if the governmental entities were to decide to terminate the contract because they could perform more advantageously, I noticed your memo says payers would still be obligated to pay outcome payments, early outcome payments, and any remaining project costs to cover services rendered. So if you could just talk us through what that stuff is.
Sure. So essentially what we're contemplating here is that some assembly of the payers coming together and saying we can do this more advantageously on our own without the pay for success structure. And let's say, I'm just going to use an example, this is a 5-year project that happens at the end of year 3, and so impact investors have put up capital for the first 3 years of the project, and they put up the money with the expectation that it's going to be a 5-year project, and their returns will be based on 5 years of outcomes. So what we're asking is that for those 3 years that they put up money, that the payers make the outcomes that have already been measured and make the payments that are due on those. For individuals that might be midstream, meaning that we haven't been able to observe an outcome, our independent evaluator will make a determination if they can assess those individuals' outcomes. So if there are early outcomes, it'd be paid on those basis, and then to the extent that there is a shortfall from the principal that the investors have put up, that amount is covered at a pro rata share. And so essentially what we're saying is that at a minimum, investors' principal investment will be covered under a situation where payers come together and say, we're going to do this advantageously going forward. Investors will get their principal, no return for the dollars they've put up, and then there's a clean break, and the assembly of payers will go forward with the project on terms they agree to. Would you add anything?
I may just quickly add to that, if I may, that all of those costs would always sum up to less than what has already been approved and set aside per the annual deposit schedule that Central Health has approved. So it would never exceed money that has already been set aside for the purposes of this project.
If I may,
Sure.
Mr. Chairman, one other related question. You stated that the impact investors would not put the entire 16 million and change into an account up front, which I understand. But would they be putting an equal amount into the account per year of each of the 5 years? And if not, how would that be determined?
Yeah, so we, investors will legally commit collectively $16.3 million over that 5-year period.
Right.
And the schedule on which we take in their capital is all based on the ramp up. So in year 1, and I don't have the exact numbers in front of me, I think we're serving 75 units, and then we look at the cost. So we're taking all the money up in year 1, and we're drawing that down, and then so on and so forth. So it's all based on the service, the cost of the program over that 5-year period, and that's the advances we're asking them to put in.
Anderson.
I'm used, you may have covered it this year last. So
That's okay.
so sorry. But I was wondering if there's any efforts being made to make sure that the racial makeup of the residents reflects the city. You may have already.
County.
The county. So I want to make sure that African Americans are well represented in the residents.
In terms of the population that's experiencing homelessness, that will be included in the project. So we're looking at, and I don't have the racial makeup in front of me in terms of what the racial makeup of the population that's experiencing homelessness is, but our eligibility criteria does not have that as an explicit criteria. We're looking at individuals with a minimum of healthcare utilization, a minimum criminal justice utilization, and chronic homelessness.
Criminal justice is where a lot of African Americans will be excluded. So just want to be super careful that that's not.
So that is one that you have to have a minimum criminal justice activity to be
Have to have something.
to be eligible, not excluded from eligibility.
Awesome. That's what I wanted to.
Furthermore, if I may add, we're actually ranking the list based on number of historical encounters and starting from the top. So the target population are actually those who have the highest number of encounters across criminal justice and healthcare systems.
Awesome. I wanted to, that's what I wanted to hear.
It's inclusion, not exclusion.
Yeah.
Manager Jones?
Okay, I know you've discussed with him what happens in the scenario where parties separate and agree, and it sounds like you've come up with a strategy. I guess my question is, what would be the expectation then of those partners who have decided that they don't want to continue this initiative in terms of reaching the expected outcomes of what the initiative originally were? So we're expecting to be able to reduce homelessness through these efforts, and if we, meaning Central Health and maybe the city and others, decide we don't want to, is there some expectation that we will continue the outcomes or some elements of the outcomes, or we're just going to say we're going to cut the program and end it?
So the idea would be that we get
at a minimum, the governmental payers together, and then these other nonprofit payers, if they're so willing to participate. And this is really a covenant, not only with the community, but those people that are in that program, that are being served, to say, listen, we can continue this. And so the idea being that we would continue it all the way through. Not to say that we wouldn't, for instance, use some of our resources within the city or the county or central health to be able to fulfill some of the functions. So I don't know about the vendor contracts, if you will. We haven't, gotten that far, but that would be part of the whole negotiated buyout, if you will, of this project, is to be able to make sure that there's integrity, and we're supporting those 250 individuals that are being served by this program. And if I may, if that answers your question, I want to go back to a previous question that's
But just
somewhat
one
related.
other point, so we would ensure that that continues. I guess my question would be, we should not be entering into this if we even go into, I understand from a business point why we're doing it, but if we have real concerns at this point, we shouldn't be entering into a process like this and then with the expectation, okay, we're gonna have to absorb it later, is what I'm saying. So I think we should be of good faith if we're going to go into this effort, I guess is where I'm going.
Correct, yes. And understood, and I think that's the whole idea, is to make sure that we can, if we are even going to sit down and start entertaining those discussions, let's say sometime just prior to month 36 in this project, that we would have done all of our spade work amongst all the participating entities. And, I don't want to speak for the city and the county, but come back to the leadership bodies to say, look, we think we can put a package together to be able to buy this out. I think that's a positive step for the community based on the work that they've done, and then to continue that on. But again, those discussions would need to start well before month 36, and you would know whether or not we're going to be able to satisfy what the original intent was of the program that you all have started. Coming back to an earlier statement, there's, again, all this is in draft form, but there's a schedule of capital calls, and thank you all for sharing that, where after month 36, sometimes it's 6 digits, sometimes it's a little over $1 million, but essentially what you would do is you would go to the impact investors and say, you're no longer on the hook for these future capital calls. And so we would assume the funding of that amongst the remaining, the payers that now become take the place of the impact investors. And those capital calls would, I didn't do the math real quick, but, it could collectively between us, again, it could be six figures, or it could be around, I think 1.4 million was the largest capital call once you got past that 36-month period, if I remember correctly. So very manageable amounts, even just among the 3 governmental entities.
Yeah, I'll just remind, the capital calls are on a 6-month basis for clarification for everyone.
Okay, thank you.
So they're not annually, but it's biannual. Okay.
Manager Akins, any questions? Any other questions? Thank you all for coming.
Thank you.
All right, we're gonna go to agenda item. Did you do everything?
Going to go into closed session.
Huh?
Oh, no.
This agenda item 10, discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform incentive payments, district projects, community care collaborative, including health care delivery arrangements and other community partnerships.
Do we need to read 7 also for closed session?
Yes, please also read 7 before you make the
Right,
announcement.
but do I read it now, or do I read it back when I
We'll
went?
get a closed session.
Okay. Agenda item 7, discuss and take appropriate action on the use of new initiative funds during the fiscal year 2019, including an agreement with Social Finance, Inc. and its subsidiary Path LLC for permanent wraparound services to be provided to homeless Travis County residents. Right?
Now I'm ready.
I announce that the board is convening in closed session to discuss agenda items 7 and 10 under section 551.071 of the Texas Government Code, consultation with attorney. The following staff may remain for closed session in addition to our counsel, Hallie Gummit, Mike Beaslin, and Lisa Owens. Let's take a 5-minute break, and there's food next door if you have any
still
No.
closed.
If he had to leave, we'll still inform him if he left.
Oh, is that right? Okay.
Right? All right, it is 8:26. Today's June 19, 2019. Let me read the language of item 7, which was discuss and take appropriate action on the use of new initiative funds during fiscal year 2019, including an agreement with Social Finances, Inc. and its subsidiary PATH LLC for permanent wraparound services to be provided to the homeless Travis County residents. Vice Chair.
Yes. I move to amend the board's previously adopted action to designate $300,000 from the new initiatives funds for the Pay for Success project, which action was taken by the Board of Managers at its May 29th, 2019 meeting by substituting the following dependent clause at the beginning of the original motion, : contingent upon Social Finances Incorporation of the first and fifth conceptual terms presented at the May 29th, 2019 board meeting, and a provision that would cap the return to social impact at 9%, and incorporation of a modified version of the third conceptual term presented.
Do I hear a second?
Second.
Okay. Any further discussion? Seeing none, I will need a hand count because I need a 2/3 vote. So there's 7 of us, we need 5 to make this motion pass. All in favor, raise your hand. All right, all against? Any abstentions? Motion passes. It was 6 to 1. All right.
I,
Let me read
Yeah.
agenda item 10.
no, it's still under 7.
Still under 7, okay.
Okay.
All right.
I further move to authorize Central Health's president and CEO to negotiate and enter into a contract with PAATH, LLC, for the Pay for Success project on terms similar to or more favorable than those presented to Central Health this evening, and including a specific acceptable definition of project costs.
Do I hear a second? All right, so I have Manager Greenberg, Manager Bell, being seconded. Any further discussion? I do not need a 2/3, right, Carly? Just
That's
okay,
correct.
so a voice count. All in favor say aye.
Aye.
All against say no. No, any abstentions? Motion passes. All right. Agenda item 10, discuss and take appropriate action on the 1115 Medicaid waiver.
Hang on a second.
Sorry,
Go ahead, Council.
sorry, Council.
We changed it up on here, so I apologize.
All right, okay.
We don't have action on 10 tonight. We've discussed it in closed session. so
It's
we can
informational.
Move on to the Sendero item, which I
Okay.
believe is.
Number 11.
All right, so this agenda item 10 will be just an informational item, no action will be taken tonight. All right. All right, agenda item 11, discuss and take appropriate action on the update regarding Sendero Health Plans, Inc., including the effects of federal legislative and regulatory actions. Wes, thank you for coming. Dr. Allison, thank you for being here. Betty, thanks for coming.
So yeah, thanks for the chance to be here with you and share what we know to date. I would say with 2 limitations, and one is some of the competitive nature of some of the supporting detail. And the second is just on the availability of data. So this meeting is coming a little bit earlier in the month, if you don't have much of all the information we expected to have, specifically the actuaries. Today's 6/19, very last one. And then the board, it says second from the bottom. Oh, so the availability of data, so we've just got 2 slides, but it should have a good information in it, so. Slide 2. Oh, sorry, I'll walk around. I'll just, I can sit. Is it easier if I sit? Okay. Yeah, that's fine. Where we're going, so for the availability of data, I thought we'd start with slide 2. and talk a little bit about the timelines. So we were here in May discussing what we could about Q1, the public filing. We reported basically break-even performance. Tonight, we can share and discuss much as we can a preliminary draft of 2019 projections. When I say preliminary draft, it has been reviewed by the actuaries. The actuaries don't have all the data that we would have hoped to have. June 24th, Monday, there's a Sendero board meeting where we will be reviewing the same slides and having some more discussions about those. Sometime in the next few days, we don't know when, we were hoping we would already have it, we will get the Wakely 2019 risk adjustment. That is one of the biggest missing pieces. So the holdup on that is that the actuaries crunch it for the whole country. They kind of go state by state. So we've already released like about a dozen states, but not Texas. So any minute now, they come all times day and night. We'll find out. Once we have that, then it'll make the pictures a lot clearer. Also for us, like as a footnote, June 30th, we should have our final 2018 audit results. We have a preliminary audit, but I don't have any scheduled adjustments or anything, so nothing to discuss. The audit. In July, what this means is that we can get Donna, this gives time for Wakely and Donna Novak to review the claims paid through June and that risk adjustment estimate against the business plan projections. And basically, we're looking at three things. One is give us end of year projection for the rest of 2019. The second is kind of help us point out, define the main drivers of any differences versus the business plans that were discussed last year. And then the third is some guidance on the 2020 business plans based on what we see. And then July 24th, as I understand, we'll be back here in this room, I think, right? So there will be a Sendero executive session called, which you will be invited in to participate. And that is nice because that will allow us to discuss more in detail, or pretty much as in detail as we discussed with the Sendero board, all of the data that we have in the plans. Next slide. So I mentioned some preliminary draft projections. This incorporates claims data paid through June 11th and an estimated risk adjustment. So what we have to date is member level risk adjustment for the members we have. We do not have any indication on what's going on in the rest of the state, though, and so that's the part we need Wakely to weigh in on. Preliminary review indicates overall performance financially sound with significant year-over-year improvement versus last year. Even with CHAP Care running significantly greater than forecast. So the idea was that basically, if I was going to really briefly summarize the business plans, it was to provide benefit to the MAP members and Central Health in terms of providing care for those members and do so without any detriment to Sendero. And that is what we expect to be happening. We'll have more details on that later. But right now, we can say with the actuaries that projected net incomes and the surplus towards RBC suggest margins in capital likely sufficient to continue into 2020. And down at the very bottom, we have three projections. To kind of jump to the chase, if you look at the far right, we have our capital number, the RBC percentage. That's the risk-based capital percentage. That's kind of a quick statutory measure of kind of like the regulatory requirements or the strength of the capital position of the company. And in any of the scenarios, so the top scenario is just a basic straight line forecast based on what we know so far, what we think will happen for the year. You see that one shows a projected possible net income of $2.9 million. The second one is basically the first projection with an additional 5% adverse trends. So net income is a little bit below break even, about a $700,000 loss. Even in that scenario, we still end the year with a 400% RBC, which is as high as it's been, over the past years. The last scenario is a 10% deterioration where we are. And in that case, there's a $4 million loss. But even in that case, we still end the year with a projected year-end surplus of $9 million, which, given our business plan, should be enough to go forward into next year. So I'll open it up now and see if Dr. Bell or anybody wants to.
Dr. Bell? Thanks, Wes. Members, what you're hearing is that wanting to come to you guys with information to fulfill the motion that we outlined at the meeting in September the 22nd. So far, the staff have kept us apprised of the issues going on with Sendero. As you realize, we had a closed session issue that doesn't allow us to protect information from Sendero's competitors. Our legal team has come up with a way that we can protect that information and also have a robust discussion about the status of Sendero. I think Wes has outlined fairly clearly that financially, we are not nearly as bad as we were last year, okay? But there's still some volatility in our figures. And we need to be able to explain to you in detail where that volatility is. And in those explanations are things that would sort of give competitors some idea about the company that they could use to undercut us or to try to really drive us out of business. So we will have a full discussion of this at the next Budget and Finance meeting on July the 24th. We will have the Sendero board here, as well as the Sendero staff, and we will all join in on a discussion. So I don't want you guys or the public to walk away and think that everything's rosy. It's not, okay? There's still some volatility in our numbers, and we want to make you aware of what it is, and we also have to lead up to the decision with regard to the CHAP patients, okay? Because our strategy with regard to finance worked. I think we provided care to those very, very expensive clients that we had. But I don't know that we predicted very well how expensive those clients were going to be. And so that has an effect that we need to look at. Okay? Questions?
Sure.
So, thank you, Manager Bell, for that explanation, because I was very concerned that I didn't want the public and others to be led down the primrose path, because it is my belief that I certainly do not have sufficient information with what's presented here, as you stated, to make any kind of decision on the true fiscal situation and what that would mean for us and what decisions we should make, or I should make as a board member of Central Health in our upcoming budget. So but I do understand that there are issues that could put Sendero at a competitive disadvantage. So I thank you. I look forward to the July meeting where hopefully we'll be able to get all of the additional information, some that you have said that would be forthcoming, thank you, and some that you have alluded to, and I appreciate that, so thank you.
Manager Massetti?
Thank you, Chair. And thank you, Dr. Brown, and Wes, and everyone from Sendero, appreciate it. I think this date, I will never forget it in my life, both personally and professionally. And I think we are in the business of providing help for those who need it most, and we have accomplished that. And I'm happy to know that we have delivered care and service for those who are really sick of the sicker. You know, I think the population, and I think we, as right now, Dr. Bell alluded that we probably did not we not estimate the cost, and I don't know what the cost is for those sicker population. And when, as a board member, I'm looking at how can we better serve more people. And I know we were focused on those 232 really chronically ill patients, but as this decision boils down, where can we more invest to provide more for more than those people? And I will not be present on the July 24th meeting, but I will be following things very closely. But whatever decision we make, it will be a difficult decision. Whatever in the future for Sendero's
Budget.
sake, I think that's what I'm saying. I'm not saying that we're gonna make a decision, but we're gonna look at it from all scales, from those people who were we recently enrolled into CHAP, and overall the community that we are providing. We understand that Texas is one of the highest states of uninsured individuals, so it's a difficult, whatever way it is. And again, thank you for this information, and look forward to looking at the money, the fiscal, the data.
Manager Bell?
I did want to say there is one positive note, and that is from looking at the financials, it looks, and it's very possible that we will not, Sendero will not need any capital from Central Health.
Yes.
So, what?
I'm thinking back to our prior motion where
Yeah, well,
there wasn't going to be future injections of capital, was my recollection.
Well, there was a cap, if you look at the
Okay.
motion itself. All right, we had to develop a cap at
Understood.
that point.
Okay,
So you can develop a cap if you like, but we don't need any,
thank you.
okay?
That is a positive note and duly noted.
Manager Jones?
I want to commend you all for at least for following the intent of what we asked. We set some parameters and expectations. We recognize that we're still not out of the woods yet. But the whole purpose of it was to be able to assure us as board members and the taxpayers that we're being due diligent. And I think that you've done a good job in helping, at least me as a board member, be able to feel somewhat comfortable we're heading that way. So I want to admit that as well. As we go forth, what we want to encourage is that, and I'm sure you understand, you don't drop the ball, that those expectations are still there. But I feel good, and I think the board should feel good that we took the risk and we made the decision to go ahead. So thank you very much for helping us to feel that we made the right decisions in those things. But the expectation is you continue to get us to where we need to go. So I just wanted to give that editorial comment.
Thank you, Manager Jones. Any other questions? Manager Valdez?
It's not gonna be a question, I just wanna thank you. And of course, yay, Sendero. But I do greatly appreciate the work that you continue to do in our community for as long as you've been in existence, especially under your leadership. You have brought them to this point where, I think it's a wonderful thing for you to even say possibly we are not going to, thank you, Dr. Bell, have to ask you for any additional dollars. But understanding the fact that you are not really operating under the best circumstances with respect to timing and the ability to enroll CHAP members, taking all that, the short enrollment period, the fact that we were moving people into and having to develop a protocol for even talking to those prospective CHAP members and moving them into a comprehensive insurance plan as opposed to this, siloed program that we offer under MAP. I think that y'all are to be commended, that the eligibility team is to be commended, and everybody who worked to bring us to this point. So I thank you very much. I look forward to including you in our budget, and I look forward to the July 24th meeting where we will hopefully have much improved, or at least better data upon which to base our decision. And I thank you guys from the bottom of my heart. I know the work that you do, and not a week goes by. It used to be day, but at least right now it's a week for me, where I don't hear about somebody that's under Sendero being so happy with the care that they have received. Thank you.
Wes, Betty, Dr. Allison, thank y'all.
Thank you.
Rudy, did you have something else to say, Wes?
What I was gonna say, no, I'd like to thank all, on behalf of Sendero, we appreciate that, you're welcome, and we thank all of you for putting up with some very hard discussions and making some very hard decisions last fall. And we're happy to say that the preliminary data shows that that was not in vain. You know, it helped a lot of
Thank you.
people. So thank you for that.
There are no other questions. Agenda item 11 was just an informational item. No motion is necessary. Agenda item 13, confirm the next regular board meeting date, time, and location. The next Central Health Board of Managers meeting will be held on July 31st, 2019 at 5:30 p.m. at Central Health Administrative Offices, 1111 East Chavez Street, Austin, Texas, 78702. And with that, I'm ready to accept the motion to adjourn.
Second.
All in favor, say aye.
Aye.
Motion passes.
Thank you, members.
Thank you, members.
Thank you, Rudy. I see you over there.